several other fellow research presentations today, starting off with Connor King from the Joints team.
Good morning. For those of you that I haven't met, I'm Connor, one of the Joints Fellows, and my research project this year is looking at same-day discharge for a majority of primary total joint arthroplasty patients at a tertiary academic medical center. So there's been a lot of literature showing success of outpatient hip and knee arthroplasty, particularly in the ASC setting. A couple of different studies over the last several years have shown that it's safe and that it also may be associated with higher patient satisfaction. There have been a number of factors that are influencing this shift to outpatient beyond just the literature that's supporting it. The department here actually learned a lot from being part of the bundled payment program in terms of how to decrease length of stay and improve resource utilization around the arthroplasty itself. And some of the other pressures include CMS removing total knees in 2019 and total hips in 2020 from the inpatient only list, as well as a host of other orthopedic procedures. And then something that we've dealt with here, but I also dealt with at my hospital in residency, is sort of the constant pages about limited inpatient beds and needing to discharge patients. And this existed both pre-COVID and continues to exist today. Patient interest was a factor a little bit prior to when this program was implemented here, but it definitely became more of a factor after COVID, patients not really wanting to be in the hospital any longer than they had to be. And then, of course, over the last 18 months, COVID certainly had a profound influence on this as well. So as we all know, working in an academic environment poses some challenges, particularly when you're trying to make quick changes that are pretty substantial. Some of the inefficiencies related to training residents and fellows sort of undermine a lot of this. And there's also sort of the bloat associated with a large institution that maybe isn't quite as nimble as a private practice or an ASC. So there are a lot of committees and sort of hoops to jump through, and it can also often feel like you're sort of just dealing with stop sign or red light after red light when you're trying to make some of these changes. So in terms of outpatient joints here at University of Utah, based on some of this growing interest and literature supporting its success, the Recon department has been working since about the middle of 2018 to first define, then implement, and then refine protocols for who could be considered and then undergo outpatient arthroplasty. It's sort of been a long time coming, and then this year sort of really forced some more rapid changes. So this was the first criteria that was sort of pushed out in our clinics in terms of who would be the best candidate for outpatient arthroplasty. They wanted to identify patients that were motivated, those that sort of weren't too apprehensive, but could be educated and engaged in the process of going home same day. They also wanted to make sure that patients had good home and family support. Having a caregiver at home on the day of surgery was seen as being mandatory. And in terms of comorbidities, if they existed, we wanted to make sure that they had been optimized in terms of reducing narcotics, quitting smoking, getting A1C below 7, ideally BMI less than 40, preferring aspirin rather than some of the other DOACs for anticoagulation, and then total joint risk score, which is a score that's been developed by the team here in terms of looking at some of the comorbidities and risk of readmission, and continues to sort of be refined over time, ideally less than 3. Wanted patients to be under 75 and again, live closer to the hospital. So all things that sort of were based on the literature in terms of identifying patients who would likely be more successful at going home same day and not having an issue afterwards. So initially this was pretty strict criteria in terms of who would qualify and be considered. And when this was first implemented, most of these surgeries were done at the UOC. There were also some changes that were necessary in clinic in order to sort of facilitate this. Nursing-led screening based on that previously established criteria was sort of one of the hallmarks. And then they also did a lot of one-on-one patient education about the outpatient arthroplasty and what they should expect from that. The department also made a number of videos for patients to have as a resource so they could sort of watch and get a sense of what to expect as to how the day would go and what they could expect once they got home as well. So initially this was pretty successful at the UOC, and they started to try and move it over to the main hospital as well, which brought it another set of challenges. And I think one of the important things that the department did was bringing the orthopedic floor nurses, with the help of the director of phase 2, brought them down to phase 2 so that those nurses could then get some education as to what to expect in terms of benchmarks for when patients would be okay to go home and how they often are post-operatively from total hip and knee arthroplasty, since those phase 2 staff weren't really at all prepared and didn't have any experience taking care of those types of patients. Additionally, we worked with anesthesia to establish new protocols on shorter acting spinals, specifically using bupivacaine rather than bupivacaine. So this allows for more fast track recovery in terms of getting motor function returning after the spinal, and also really an emphasis on decreasing narcotic utilization both intraoperatively and postoperatively. Again, all things to try and facilitate getting patients moving and out of the hospital faster and safely. They also had to make sure that PT was available to come down and see patients in recovery, since they weren't going to be going up to the floor. And to this point, no additional staff was hired. So the existing case manager took on this additional responsibility to help coordinate some of these same day discharges. So people were starting to get spread a little thin, but no additional staff was hired. And it was really, really successful initially. We're getting about 10% of primary hip and knee arthroplasties booked as outpatient as we sort of established this multidisciplinary team and program. And then obviously the last year threw a lot of wrenches into the best laid plans. So this temporary halt of all elective surgeries, given the pandemic, really sort of mucked things up a little bit. And then the ongoing scarcity of inpatient resources really necessitated a focus on shifting towards even more outpatient arthroplasty. So another couple changes had to be done to adapt to the pandemic. Joint Academy, which previously had been a sort of in-person patient education program, was moved online. And then we were also forced to relax the criteria in terms of who would be considered for same-day surgery. That strict list, it basically, when we were talking with patients, was, well, we have the option to do it as an outpatient and we've optimized you, or we don't have an inpatient bed and so we can't do your surgery. And so that sort of shifted what patients were accepting of and what surgeons were accepting of in terms of booking patients as well. So this led to the research question, which was, can a tertiary academic medical center transition from predominantly inpatient to outpatient hip and knee arthroplasty without negatively impacting complications or patient outcomes? So we looked at our own institutional registry for all primary hip and knee arthroplasties between September 2019 and October 2020, and this included the 6 months basically before and after the shutdown and then the subsequent rapid transition to predominantly same-day discharge. We looked at demographic data, patient risk profiles, including Charlson Comorbidity Index, ASA, Joint Registered Risk Score. We also looked at discharge disposition, time to discharge, and 90-day complications postoperatively. We identified a total of 1,249 patients that underwent primary hip or knee arthroplasty. There were similar breakdowns of hip and knee arthroplasty between the two cohorts, both before and after the transition. And so the first thing we did was look at all of the primary hip and knee arthroplasty, whether they were done as same day or not, just taking all comers, looking at before and after this change. One of the things we wanted to identify was whether there was any difference in the patient risk profile, and we found no difference in age, BMI, CCI, or ASA. And so it's not like there was either a self-selection or a surgeon selection in the 6 months that we had made this transition for healthier patients. We increased the number of same-day discharges from about 17% to 64%. And then, not surprisingly, that also then brought down the number of patients that were staying in the hospital more than 24 hours from almost 70% to less than 35%. And I think one of the important things we wanted to look at too was whether this had any change in the 90-day complications, and there were no statistically significant differences in emergency department visits, readmission, return to the operating room. So knowing that then these two cohorts, whether they're same day or not, were not different, then that sort of led us to look at the next thing, which was looking at only the outpatient same-day discharges. So in the pre-transition cohort, there were about 104 of these, and there were 410 in the post cohort. And interestingly, it actually showed that the post cohort had patients that had a slightly elevated risk profile, particularly looking at the Joint Registered Risk Score. It was higher. And then these patients were also slightly older. Though BMI and CCI were not statistically significant, they did trend towards also being higher. So not only were these patients not healthier, they actually seemed to be less qualified based on some of the previously established criteria. Again, we saw no differences in the rate of emergency department visits, readmissions, or return to the operating room. And I think another thing just pointing to the success of the program is that of the 440 that were booked as same day, there was a 93% success rate into to those that were discharged same day as well. So study definitely has a couple limitations. It was single institution, it's retrospective. I think one of the biggest limitations or things to sort of keep in mind is that this outpatient protocol and multidisciplinary team were established well before this rapid transition. So it sort of was an acceleration of an existing program. So it's something to keep in mind if anyone is trying to sort of implement this elsewhere. And I also think COVID had obviously profound impacts on this shift, but also it probably affected what patients and surgeons were willing to accept in terms of whether they would have their arthroplasty done outpatient. So where we're going to go from here, the next steps, we definitely want to look more specifically at those that fail to launch. Can we better predict those that will fail? And also, are there patients who are staying overnight that maybe could have or should have been done outpatient? And then once we have the 1-year follow-up data, we want to definitely look at patient-reported outcome measures and see if we have any differences in those that were done outpatient versus inpatient. So I think the take home is that outpatient arthroplasty is safe, even at a tertiary academic medical center, with all of the issues that we know that can sometimes come with. And I think the caveat to that, though, is that you need to make sure the patients are medically optimized and the appropriate care pathways and multidisciplinary teams have been established. Thank you. Any questions?
Really great job, Connor. I think one of the other things is expectations of the ancillary staff, nursing, et cetera. I think pre-COVID, it was all it took was a comment by somebody to say, oh, usually people stay overnight, probably better for you to stay overnight. And it just would totally derail our efforts to do outpatient. So I think COVID really changed the game with that. Any comment? So where you're going in your practice, they're not doing a ton of outpatient. How soon are you going to push it? What kind of resources do you visualize having to acquire? Any other comments regarding kind of the up-ramping of resources to accomplish this?
Yeah, it's interesting. The practice I'm going to has basically similar to what sort of led to this research question. The hospital has an interest in outpatient, but isn't really doing much outpatient, and the ASC is doing a lot of outpatient. And I think it's partly that they don't have the multidisciplinary team or the resources currently at the hospital. And so I think before pushing for that, I think I would definitely want to make sure that all of the groundwork that you guys did out here in terms of setting that up with anesthesia and PT nursing would be done at the hospital before really trying to force the issue there.
Hey, Connor, Mike Archibek here. A quick question. Did you guys put anything into place that was not previously in place to prevent kind of unanticipated visits to the emergency room? I think that's one of the main issues that we dealt with, is educating patients and providing lines of communications for them, even at night, to prevent them from developing issues that would be addressed if they were an inpatient without concern, but at home, they may tend to present to the emergency room more often. I think there was just a recent study about 1 in 10 patients that had outpatient surgery will end up going to the emergency room. So was there anything that you guys did differently in that regard?
So I think part of that actually was related more to the data they gleaned and their experiences with bundled payments. They really wanted to be sensitive to that in terms of cost and the implications of readmission when they were in the bundled payment. So they had implemented a number of programs for both proactive patient follow-up and then also the joint home call, so that the PAs and fellows basically cover calls from patients specifically who are arthroplasty patients overnight and on the weekends, to try to mitigate some of that, because their experience had been that sometimes the patients would get someone who wasn't as experienced, and they would then be sent to the ER for something that could have just been managed by seeing a PA in clinic the next day, or just having someone more knowledgeable talk to them. So I think that carryover was probably also instrumental in helping prevent some of the readmissions and ED presentations.
Great, thanks.
Hey, Connor, this is Peter's. Great job presenting it. I just want to maybe provide a little bit of historical perspective. I mean, this is really it's game-changing stuff. I mean, I remember, starting the conversation with other folks who were having success with outpatient arthroplasty, perhaps even as long as 5 years ago. And now we see this transformation occurring across virtually all healthcare systems in the United States. It's really the way things are going to go, not just for our subspecialty, but for almost all the other subspecialties as well. Moving out of a tertiary care environment is clearly where the momentum is. And I think, it's nice that we've shown that this is possible, but I think this is just the tip of the iceberg for orthopedic medicine overall.
Ask a question real quick, either Connor or Chris, maybe back them up. It's clear that this is, as you said, moving in this direction. The challenge that I see is the cost shift that has occurred with it. Specifically, what I mean is it's taken a very intensive program within the joint service to make this really work well for patients, with many more personnel and much more hands-on time in a clinic setting. Now, our clinic setting is hospital-based, which helps us, but many aren't, out and around the country. So how are private practices or individual offices going to manage this cost shift, which is pretty intense for the requirements needed to make that move to outpatient? And I guess the same would be for other services. And then sort of the corollary to that question is, what's left in the hospital has such higher acuity than before, that trying to move those patients quickly becomes more difficult as well. And staffing may not be accurate. Hospital staffing, how many nurses on the floor and whatnot, may not be the ratios needed for that increase in intensity. So maybe a couple thoughts around that.
Yeah, I think that's a great question. I think in some ways, arthroplasty surgeons are a little bit of they're victims of their own success. I think that as they have continued to show that they can do it at ASC and do higher volume, CMS has continued to cut reimbursements. And so even though there has been some literature showing that there actually, as you've indicated, are more intensive resources required and more sort of patient contact hours, whether it's through the call system or the text messaging service that they have here for arthroplasty patients, there are things that, even though we can now do it quickly and get them out, there are both optimization things on the front end and the back end that aren't really captured in that. And so I think from a policy perspective, it's important that we continue to advocate, not just for arthroplasty, but all of orthopedics as this shift continues. It's not just, oh, well, they're only in the hospital for this period of time. We need to make sure that the whole episode is still compensated adequately. And I don't know necessarily what the right answer is for that, besides continuing to sort of advocate for ourselves. And I do think you raised a good point too, that what's left at the hospital then being sort of higher acuity, higher cost, also has significant financial implications on that end as well. So I know it's not necessarily a great answer to your question, but I think you raised some really important issues.
Yeah, Daryl, I think what you're getting at is that the cost structure really shifts from an inpatient cost structure, hospital-based cost structure, to now the burden being transferred to the practice or to the physician, as well as risk being transferred. And I think, the way people have done that successfully is they've been able to use the facility-sided fee to help with resources. Obviously, that's been done most successfully in the outpatient surgery or ACC-like environment. But with environments like ours, where we're dealing with a hospital system, that's more challenging. And I think the future there has to be partnership, and those discussions are obviously complex.
And policy change, I would mention, and then some of our health policy fellows from the academy have really tried to be proactive in their publications on those topics to that point. And, as helpful as it is to talk to CMS with our representation at academy, it doesn't help unless you have the data behind it. So continuing to publish in this space and talking about cost, and Brooke asked in the chat that we never even got to, have we looked at cost? And the answer is no, not in this particular analysis, but it's really important that you look at how the cost probably doesn't decrease, it shifts, and publishing on the work effort and the amount of cost that goes into this is really important.
Okay, great. There are no other comments at this point. I think in the interest of time, we'll move on to Dr. Mark LaBelle.
Okay, let's make sure my mic on. Can you hear me?
Yep.
Okay. Good morning. My name is Mark LaBelle. I'm one of the sports fellows. I'm going to present to you our project, essentially looking at utilizing an intramedullary guide versus an extramedullary guide for preparation of the proximal humerus in total shoulder arthroplasty. We'll specifically be focusing on stemless implants. And I appreciate the help of my mentor, Dr. Tadjan, on this project. So brief background, the key outcome here for proximal humerus arthroplasty is to restore the native anatomy. And so there's several variables that we look at in total shoulder arthroplasty. Probably the most important is the center of rotation. The other two variables we look at are the neck shaft angle and the humeral head height. And you can see in that figure adapted from a prior paper from Dr. Chalmers and Dr. Tadjan, those variables are marked up there. And there have been several studies, many over the years, which have looked at these factors and how they affect the biomechanics of the shoulder, specifically in cadaveric models as well as in the lab. And they've shown that because the rotator cuff is so important for function of the shoulder, that restoration of these variables is predictive of a good functioning shoulder. And so that's sort of the background and the key to restoring the anatomy. Specifically in this study, we looked at stemless implants, and these have been around for several years, but they become quite popular. And the stemmed implants are intramedullary based just by nature of the design of the implant. The stemless implants, in contrast, are they're not diaphyseally based. So oftentimes they are cut with an extramedullary guide in order to maintain the diaphysis. Now, the benefits of the stemless implant are many. They're listed here: the lower periprosthetic fracture risk because you're not instrumenting the canal. You have decreased blood loss and operative time. The actual prep work is quicker and a bit more straightforward. And I think perhaps the most important point is the last one there: the preservation of proximal bone stock. And as all of you know, that total shoulders over time can have failure mechanisms with glenoid loosening as well as rotator cuff failure. And so it's not uncommon to need to convert these to a reverse shoulder replacement, 20 years down the line. And so the stemless implants offer a huge advantage in terms of long-term patient outcomes in the event that they need a revision. So here are the two guides. Unlike other forms of arthroplasty, I would say probably 95% or greater of surgeons are using the extramedullary guide located there on the left. That's the standard guide that comes with the implant. You hold it up to the arm, you decide what angle you want to cut it at. There's a little version rod that goes and you line it up with the lower arm and set it for 30 degrees of retroversion, which is your native anatomy. And then you go ahead and make a freehand cut, or you cut off the edge of that. And when you look through the technique guide for stemless implants, that's the only guide they offer. In contrast, we all know about intramedullary guides, which you see there on the right. These are typically used for stemmed implants or reverse shoulder arthroplasty. And in order to even use them with a stemless implant, specifically the Tournier Simplicity implant that we use in this study, you have to actually adapt it from a different set. They don't even actually make it. And so I think that's one of the key points to understand. The purpose behind this study is that the intramedullary guide is not something that's used almost at all throughout the country. And so our hypothesis here is that by utilizing the intramedullary cutting guide for proximal humerus resection, we will better restore the native anatomy of the humeral head in comparison to the extramedullary guide. So quick overview: this was a multi-center study. The two centers were obviously here at the University of Utah, where we looked at Dr. Tadjan's patients. He utilizes the intramedullary guide, and he's sort of leading the charge in terms of this technique. The other center was my residency back at Case Western. So the other surgeon I trained with there utilizes the same implant, but uses the extramedullary resection technique. And so both of these surgeons are shoulder and elbow trained and have done thousands of total shoulder arthroplasties and are both of high skill level. And what we did is at each institution, we reviewed every single stemless implant that they put in, and then had two independent observers measure different variables at each institution. We then averaged those and compared the two groups. So here are the measures we did. The first one is the center of rotation, and this is a figure adapted from a prior paper by Dr. Chalmers and Dr. Tadjan. And the method here is to draw two best fit circles. The first one is centered on the humeral head from the prosthesis, and the other one is centered around the calcar medially and the lateral aspect of the greater tuberosity. So you can see that in the dotted circle compared to the solid circle. You then measure the offset of the two center of rotations of these two circles. And the way we did it was the same method as the prior paper. We used an x-axis deviation and a y-axis deviation, and then used Pythagorean theorem to calculate the total the total distance of offset. In the literature, we talk about a center of rotation difference less than 3 millimeters, which is considered acceptable or anatomic. And so we used that same cutoff for our study. The second measure we utilized was the humeral head height measurement. And so this is the same patient as a preoperative film and a postoperative film, both Grashy views. And you can see you fit the best fit circle. We then draw a line along the anatomic neck, just abutting the footprint there of the rotator cuff. And then you draw an orthogonal line to the anatomic neck at 90 degrees and measure the distance from there to the apex of the humeral head. And in the literature, we talk about a less than 5 millimeter difference from pre and post-op, and that's what we used to be in our study to be considered anatomic. And then the last was the neck shaft angle. This was measured on the postoperative films. The two ways to do this is to drop a line down the canal there, and then another line in access with the implant. And actually the implant's pretty easy to see because it has a central post to it. The other way to do it is to take an orthogonal to the anatomic neck or the cut surface, and then measure that in relation to the intramedullary canal. We know in the literature that varus placement of these components is associated with poor outcomes, and most studies in the literature use greater than 130 degrees of neck shaft angle to be considered anatomic. And so that's the cutoff we used in our study. And so here's just two examples. On the left, you can see an example of an anatomic replacement, neck shaft angle of 136, humeral head height of less than 5 millimeters difference from pre-op. And you see the center of rotation there is spot on. The circle is exactly overlaid on each other from the implant versus the native anatomy. On the right, you see an example of a non-anatomic one. And although the neck shaft angle is 136 and the humeral head height's acceptable, the center of rotation is off by approximately 4 millimeters. You can see the two circles there. And this one's relatively subtle there, but I think that just gives you an idea of what we're looking at overall. And so how did we process these numbers? We essentially, after categorizing each of them as anatomic or non-anatomic, we essentially converted a continuous variable into a categorical variable, and then we were able to perform a chi-squared test to assess for significance. We then calculated interclass correlation coefficients for each pair of measurers at each institution. So here are our results. Center of rotation, we had 60 shoulders in the extramedullary group, and 70% of them had an anatomic center of rotation, compared to 51 shoulders in the intramedullary group, and 90% of them had an anatomic center of rotation. P-value there is 0.009. For the neck shaft angle, same story here. About 78% of the extramedullary group was anatomic, compared to 96% of the intramedullary guide, also reaching significance there. And the last variable, the humeral head height, we see that 63% of the extramedullary group compared to 96% of the intramedullary group were anatomic, again, reaching significance. I think if there's one slight weakness to this study, this is sort of where we had a slight issue. We looked at the interclass correlation coefficient, and we had good to excellent reliability of 5 out of the 6 measures. And so you can see that greater than 0.9 was considered excellent, greater than 0.5 was considered good. And we reached those thresholds for 5 of those variables. The only one that we did not was the neck shaft angle at one of our institutions had poor inter-observer reliability. And so I think we have to keep that in mind when drawing our conclusion. So overall, here's our conclusion, was that intramedullary guided resection was superior to extramedullary guided resection, restoring native center of rotation and humeral head height. As I mentioned, I think it's difficult to make a firm conclusion regarding the neck shaft angle, given that there was poor reliability within that one measurement. And I think that it's reasonable that surgeons should consider utilizing the intramedullary guide with stemless components to improve component positioning. So a few limitations. And I think some of these are pretty clear with our methodology, is that we only had 2 surgeon samples, and they may do some things slightly different. So it is prone to some confounding variables. That said, that's why we chose only to assess radiographic parameters that are affected by the cut angle and the cut dimensions. And so our hope is that any other differences in approach or how they manage soft tissues and things of that nature would not be playing into the outcomes that we're measuring. The other weakness or the limitation here is that we don't have any functional outcomes or pain scores. And again, we thought that may just kind of cloud the picture given some of the surgeon factors that may be at play there. We had different observers at different institutions, but we had, of 5 of the 6, we had reasonable agreement on the parameters. And so we did our best to limit the variability you may see there. And then lastly, we didn't look at the downsides associated with the different techniques. And I would tell you that critics of using an intramedullary guide from this will tell you it takes longer. You have a little more blood loss, which I would argue is marginal. And then a lot of surgeons will talk about being concerned about violating the canal and losing your fixation of your implant and your metaphyseal bone. In Dr. Tadjan's patients, we have not seen this happen in anyone, but that's what some of the critics will mention as a reason to avoid it. And so I think a larger study, you could assess these factors to sort of put people at ease as to how they affect the outcome of the patient. I think next steps for a study like this is, I think this would be a good study for randomization. You don't have ethical concerns here. We know that most people are using the extramedullary guide, and other than adding a little bit of time to surgery, there's not a major downside that we can tell. And I think it's something that we could consider in the future. And then the other thing is to include more surgeons. I think if people were open to adapting an intramedullary technique, and we had more surgeons that were willing to try it and move forward with it, you could get a very good sized study with multiple surgeons and randomized your patients to the 2 groups. So I think those are sort of big picture steps where you could go with this study. I thank you for your attention. I open any questions or comments at this time.
I think it was a great, this is Charles Saltzman. I think it was a very good presentation, and you did an excellent job with the study. I do think the numbers matter, and looking at the outliers and why the outliers happen matters, and just grouping things categorically sort of blurs maybe the real risk here. So I would say consider a little more analysis of the data, or when you submit it for publication.
Thanks, Dr. Saltzman. We based this off a similar study that was just published in JSES, and that it was similar methodology. But I think your point is fair. I think one of the limitations is that our numbers aren't huge. Our post hoc power analysis showed approximately 0.8 on our beta, but at the end of the day, I think your point is fair, and this would be something that hopefully will kind of open other people's eyes to considering using this technique, and then we would be able to repeat the study with bigger numbers.
That's fine. I still think the numbers matter, and the outliers really matter.
Yeah.
This is Peter Chalmers. I think this is a super interesting study just because it goes so against what everyone is saying right now, that the benefit of stemless is you no longer need to reference the canal, and then you can put the implant in the perfect spot. And I think this really suggests that when you do that, you don't put the implant in the perfect spot, and the canal really helps you to put the implant in the right spot. So I do think this is going to make some waves, and my hope is that it leads to a change in technique, especially for surgeons who may feel less comfortable. And I would say that maybe this could, at the very least, make all of us feel a little more comfortable using the guide, and make it feel like maybe we're not inadequate surgeons if we have to use the guide.
Yeah, Mark, great study. Thanks for doing this. I appreciate it. And I think I agree with Dr. Saltzman that we can work on the data, and we can kind of, I think we can do a little bit more analysis. Also, we can work on the ICC. I think that we had talked about that it might just mean reevaluating those radiographs after teaching how to actually be consistent between the methods. But I think the 2 issues are that the concern of using an intramedullary guide with a stemless is that surgeons were concerned that they'll be violating the canal. And even though it's a very small diameter structure that's going down the canal, that then would limit the fixation with regards to the implant, and haven't seen that. So I think that's one hurdle to overcome, that just the mere fact that presenting cases that we actually have this number with an intramedullary guide, it might make people more comfortable, say, okay, you can do it without compromising fixation. The other is it gets to surgeon hubris, and that we all think that we know how to do shoulder arthroplasty after you've done a number, and that you can just cut based on what the patient's own anatomy is without any type of guides at all. And I think that that is the thought process with regards to many surgeons in shoulder arthroplasty, that they don't need any guides because they can identify the anatomic neck. I think this points to probably we're not as good as we think we are, and that using other instrumentation in the operating room besides just surgical experience can be helpful. So anyways, good study.
There's one comment in the chat from Lucas Marchand. Interesting, you took a continuous variable and made it dichotomous. We usually try to go the other way.
Yeah.
Statistical power purposes. Any comments on that?
Yeah, I think that's also getting at sort of at what Dr. Saltzman was saying. I suppose we could analyze the data differently. In the literature, it was felt that those cutoffs were what were clinically important, and so that's why we did it and modeled it after some similar studies. And I think it's a fair criticism, and it's something that we will consider. We're submitting this in the next month or so here, and have a draft written up, but I think we can consider presenting it both ways.
Okay, great. Thanks, Mark. Next, we have Dr. Dev Padia talking about the role of patellar resurfacing in distal femoral replacement.
Hi, can you guys hear me?
We can.
Okay, great. If Mark can unshare his presentation, I can share.
See, how do I, oh, here we go. There you go.
All right. So I'm Dev. I'm the fellow on sarcoma service. I'm from India, so please excuse my language and pronunciations. I'm going to present my research fellowship presentation on role of patellar resurfacing on outcomes of distal femur replacement in distal femur tumors. My presentation was contributed by with the help of Dr. Jones and
Hello.
Dr. Brown. Yeah. So the objective was to compare the clinical and functional outcomes in the patients who had tumor endoprosthesis, also known as megaprosthesis, with and without patellar resurfacing. Are my slides moving at your end?
We can see your screen. Right now it's on one titled Objective.
Yeah, but for some reason it's not moving. Correct. Let me.
You may have to close the, yeah.
Oh, I'm so sorry.
And reopen.
Am I audible?
Yep.
I don't know what's going on. Trust me, I practiced this yesterday.
You need to open the PowerPoint again. Close it and open.
Okay. Okay. Thanks, Dr. Saltzman. Okay, sorry about that. So patellar resurfacing has been always controversial. There are two schools of thoughts. One school of thought is that, if you do not resurface the patella, then it can cause to the anterior knee pain. And another school of thought is that if you change the patella, if you resurface the patella, then it can, need a revision surgery because of loosening or some other reasons. The challenges that we are facing in the tumor surgeries is that the age is very widely distributed. Either the patients are very young, or many a times the patients are very old. Also, if we are doing it on a case of osteosarcoma, then the patients tend to be younger. A lot of times there is an extensive bone and soft tissue resection that is done, which also affects the clinical and functional outcome. The implants that we use are mainly constrained rotating hinge that have their own limitations and also kind of affects the function. Complications that we mainly face is extensor lag, because we don't really know where is the joint line in this kind of resections compared to the arthroplasty. What I personally noticed when I was preparing for this presentation, that some studies, they say that patella surface is associated with external mechanism failure. Some studies, they show that they decrease anterior knee pain. Some studies say that there is no difference. And there are other studies that show that patella resurfacing have more chances of knee operations to revise and things like that. So this study is a retrospective cohort study. Resection of distal femur was done in patients, total 75 patients from 2011 to 2020. The cases were done by Dr. Jones, Dr. Groundland, and Dr. Randall. And we have included even patients who are less than 1 year in follow-up for this study. We excluded extraarticular knee resections, patients who had patelectomies, patients who had expandable prostheses, and sometimes distal femur is warranted in proximal tibia replacement also, and those kind of patients were also excluded in this study. Chi-square test was used for categorical variables, and multivariate linear regression models were used that could have potentially influenced the knee pain, range of motion, and extensor lag. There are two sets of variables: patient-dependent variables, that is age, gender, diagnosis, and follow-up time. Surgical variables were patella resurfacing, mean femoral resection, and type of prosthesis. The outcomes were measured as anterior knee pain, range of motion, limb, and extensor leg. And everything was measured till the last clinical visit. The complications that were found with the patella study was that first, instability and any sort of patella clunk, subluxations that were visible on radiographs, impingement that was seen on the lateral radiograph, and any degenerative changes. These were the diseases that were included right from primary non-aggressive tumor to all the way sarcomas. In this data collection, the most significant thing was a mean age group, which was 40 in resurface and 28 in non-resurface. Rest all gender, resection, primary versus metastasis, nothing mattered to the outcome. Also, anterior knee pain. So there were total 4 cases where the patella was resurfaced and the anterior knee pain was reduced in those revision cases. All right. The patella complications that we faced were articular degeneration, impingement, and patella subluxation. So the mean range of motion between resurface and non-resurface was 105 degrees. Patients who were older had more extensor lag. There was no significant difference between anterior knee pain and limb between the two groups, resurface and no-resurface. And patella complications were not different in resurface and non-resurface group. The limitations to the study were it was the retrospective in nature. The information was mainly based on the medical records, and there was a selection bias. Conclusion, resurface was mainly done in patients who were older. There is no difference whether you resurface or don't resurface in anterior knee pain, limb, range of motion. Age doesn't play any role, and the decision to resurface or not to resurface is dependent on patient's symptoms and the radiographic degenerative findings. In our study, none of the patients who had patella replacement were redone for a revision of patella resurfacing. In summary, the decision to resurface is completely dependent on the clinical judgment of the surgeon. Questions, comments? Thank you.
Very good. Thanks, Dave. Appreciate the work that you put in on that. So the question isn't so much once you have a 40-year-old or someone older with a megaprosthesis replacement, but when you have a 12-year-old or a 14-year-old, whether to resurface or not, I was taught by the people teaching me both in residency and fellowship that you would not, because you'd hope to save the patella for later so that when they get a revision, which they're going to get if they survive their cancer, they'll get several revisions through their life, that you have saved the patella for that later time. But my experience has been when I've done these revision surgeries is the patella is completely dysmorphic and has not actually been saved at all, but is actually quite degenerative and molds itself around the endoprosthesis. So the question would be for you, Dave, would you resurface someone who's 15 years old or 20 years old, anticipating a life of 60 years with an endoprosthesis?
I think sometimes age does matter, especially in this kind of situation. So if it's a younger patient, I would not change. But if it's an older patient who already has radiographic findings suggestive of arthritis at the patella, I would change.
Fair enough. That's kind of the conventional teaching. I'm kind of leaning the other way myself, but haven't been convinced yet by any specific data.
Right.
I think the study highlights how complex the issue is, and there's a high prevalence of anterior knee pain no matter what, and that's true in primary knee replacement as well. And then we're talking about distal femoral replacement, which we do a lot of for arthroplasty salvage, but in the setting of tumor, you're in this situation of there's just such bigger fish to fry. Like they get to keep their leg, they get to walk. Isn't this a great success? And now we're worrying about the patella.
Yeah.
But when you're talking about this, there's so many other variables, whether it's the rotation, you talked about subluxation or lateral tracking. Did they have any other complications? What was their range of motion? Did they get an infection? Did they get radiation or they didn't get radiation in their sarcoma bed? There's so many factors that may also play into this, and the numbers available with the study just probably aren't enough to highlight the importance of whether the single variable of resurfacing or not was important. So I guess I kind of agree with the conclusion, which is you kind of leave it up to your best judgment, knowing that they're probably still going to have anterior knee pain no matter what you wind up doing, and trying to nail everything else that you can is probably more important in my opinion.
And I think tumor patients like in India, we always say beggars cannot be choosers, So whatever they get, they have to take it. So.
Okay, thank you,
Very
Dave.
good. Thank you.
Welcome. Thanks.
Well, we managed to finish right on time. I think that concludes things for this morning, unless there are any other comments or thoughts. Okay, take care.